Ladies and gentlemen, do you think we can get started? Thank you. Thank you a lot. On behalf of myself, the Digital Square team, the PATH team, our coordinators and our partners in helping organize this event, the World Economic Forum, the government of Brazil, the World Health Organization, and most especially the Wellcome Trust, who have been instrumental in helping us pull together today, I want to say both a warm welcome and thank you for taking the time to be here. We're at a critical moment for artificial intelligence in health. The opportunity seemed to be, I'm going to lift the mic up, no? Can't hear me. I'm getting some signals. Oh, there we go. Now the mic works. Is that better? Should I restart? I think I've said thank you to everyone who helped us organize this event. So I'll get on with it because I appreciate that everyone wants to get to the cultural event on time. Are we good? Excellent. Onwards. So we are genuinely at this critical moment for artificial intelligence in health. The opportunities seem to be growing almost exponentially day by day, and it's the decisions that we will make in this brief window that we have over the coming days, weeks, months, that will decide whether we achieve the one goal that I know we are all committed to, which is to either close the inequality gap, but we must recognize at the same time that this technology presents the risk that it might also exacerbate that gap. In the space of AI for science, a great example that I think demonstrates that double-edged sword is the recent release of AlphaFold 3. Our colleagues at DeepMind released this most recent iteration of the model that goes beyond just protein structure prediction to include DNA, RNA, ligands, and their interactions. And in doing so, presents an opportunity to transform our understanding of the biological world, but more importantly, to transform how we do drug discovery and development so that we can meet the ever-growing health needs of our global population. However, in deciding not to release the underlying source code, in limiting the types of queries and the number of queries that one can undertake with the web service they provide, we have limited the ability of the academic community to test that model. And in doing so, we have undermined the trustworthiness of the system. There will always be a balance that needs to be struck between commercial interests and transparency, but I think our responsibility in this room is to ask the question, are we doing enough to make sure that the opportunities this technology affords are being realized globally and equitably? And credit where credit is due, when AlphaFold 2 came out, our colleagues at DeepMind partnered with the European Bioinformatics Institute to make sure that every single protein structure prediction was made available openly for use by researchers. We can find solutions that walk that line. We just need to be creative in our problem solving to do so. Let me take a moment and switch tact to AI in healthcare. The conversation of the hour seems to be large language models. LLMs, they're everywhere. I imagine everyone in this room has used one now. And what they've demonstrated is this suprahuman capability and performance on medical licensing exams like the USMLE. But what we need to recognize is that there is only so much you can understand about their safety and performance from a multiple choice question, right? That does not speak to their performance in the real world. And I want to give you just two examples of why I think that's such an important reflection for us to hold on to. The first comes from an in silico evaluation carried out by a large US hospital system that used a large language model, an LLM, to generate responses to queries from patients that would otherwise have had to be answered by overburdened doctors. And when they reviewed those responses, they identified at least one of the 156 that they evaluated that would have directly led to the patient's death had they had access to it. Just short of 10% would have caused significant or severe harm to the patient had the advice been followed. The use of this technology in healthcare has real risks. Equally, the practice of medicine has real risks. My argument here is not that we shouldn't use this technology, but that we need appropriate evidence that speaks to context, that ensures that we have adequate safeguards to make sure we're using the right tool at the right time. Couple that with the fact that less than 3% of all randomized control trials that have ever been carried out for AI-based tools have been carried out in Africa. One in Malawi that was funded by our colleagues at the Wellcome Trust, and one in Rwanda. There is a genuine paucity of evidence that demonstrates this technology does what we expect it to do in the communities where we think it can be most impactful. And if we do not address that gap, we will never realize the full opportunity in front of us, or at least we won't do so equitably. Today, in this afternoon's sessions, is about celebrating the enormous progress we've made in AI and science and for healthcare service delivery. But it's grounded in a reflection that we asked each and every one of our speakers to include in their remarks, which is how do we do so responsibly? And I can think of no better way to kick off than to ask for the reflections of our host. We're here at the G20, who better to hear from than the government of Brazil? And so what I'd like to do is invite up first the moderator of our fireside chat, Diana Vaca-McGee, who serves as the World Economic Forum's healthcare policy lead, working closely on positioning the forum's work with multilateral organizations and within the G7 and G20. She's worked in global health as an international affairs expert, covering a range of health conditions, but also focusing on diversity, equity, and inclusion efforts. Relevant to this dialogue today, one of the key policy areas that the forum is actively advancing from a private-public sector collaboration perspective is AI in health by its flagship Digital Healthcare Transformation Initiative, which is closely coordinated with us at PATH, the WHO Global Initiative on Digital Health, and the G20 process. And she's joined by Secretary Ana Estela Haddad, the Secretary of Information and Digital Health at the Brazilian Ministry of Health, full professor at the Faculty of Dentistry at the University of Sao Paulo, Deputy Coordinator of Public Policy of the Public Policy Research Center at the Escola de Metropole at the Institute of Advanced Studies. And she was formerly the Director of Health Education Management at the Secretariat for Work Management and Health Education, coordinating the creation of the Telesaúde Brasil Redes, Brazil's telehealth network program. I know we're all excited to hear her reflections, so I'm going to hand it over to both of you. Thank you so much.
Thank you, Bilal. Thank you all for joining us today. And thank you. Thank you, Secretary Haddad, for spending this time with us in your beautiful country, for welcoming us all today. And so we're going to start with, I think, one of the biggest questions about success. And being that Brazil is holding the presidency, how is it that you're seeing success in this space that's so critically important to the health of your people and the health of the world?
Well, Diana, first of all, I would like to thank Bilal, Dr. Bilal, thank PATH, WHO, and the Global Initiative on Digital Health, Dr. Alain Labrique. Also, I would like to say especially thanks to Dr. Socorro Gross, that represents PAHO and supports here Brazil in all our initiatives. Also, a special welcome, a special compliment to Professor Mauricio Barreto, who is here. He's from Bahia and Salvador, and everybody. Well, I hope you are very welcome to Brazil, and also especially to Bahia. Bahia is a very special, and Salvador, its capital, it's a very special place for us in Brazil. We cannot imagine our culture without Bahia and without Salvador. Not only the beaches, but the history. We have important singers that are famous all over the world: Caetano Veloso, Gilberto Gil, Daniela Mercury, Gal Costa, Maria Bethânia, and so on. And you will see later on a very special number on culture. I hope you don't miss it. Olodum, okay? Be there. We'll go to the Pelourinho to listen to Olodum. I think you will love it. Well, sorry, Diana, for not entering directly into the subject, but it's important for us to, breathe and feel more comfortable. And also, we are just arriving from the WHO, the World Health Assembly. Probably many of you were there. And, for me, well, for us here in Brazil, we although our minister Lízia Trindade could not come personally, could not go personally because of what we are facing in the south of the country, the tragedy that we are having, and she's taking care personally of that. But our delegation, we made special advancements, we think. I would mention the resolution about social participation, which is very important for our unified health system. And we are proposing for next year a resolution on facing the digital marketing against how do you say? I forgot the children breastfeeding, child breastfeeding. Well, AI is the subject everywhere. And in this G20, we think that it will be very important that we want digital health to discuss both as an interdisciplinary way, in a comprehensive way. First, meaning that digital health is profoundly intersecting with other G20 working groups, prevention, preparedness, and response to pandemics, health equity, and climate change. We will miss opportunity for fruitful debates if we do not understand health as deeply interconnected and influenced by social and digital determinants. And on the other hand, understanding digital health comprehensively means understanding that the power of telehealth, innovation, digital public infrastructures, and artificial intelligence need to be accompanied by target investments, scalability at regional and global levels in order to ensure equitable access to digital health. Nationally, we have been advancing in a new law for AI in a broad sense, not only for health for now, but we are improving also and moving forward in discussing AI applied to health. And President Lula just demanded for the government for a Brazilian plan for developing AI also. And so we are working on that. For artificial intelligence, Brazil is committed to the development and equitable access to safe and effectively AI-based tools. We advocate for the inclusion of the commitment in the Declaration of Ministers of Health and invite all countries to support it, ensuring no one is left behind. Additionally, we seek a consensus among G20 partners to engage their regulatory authorities in collaborative efforts. This will facilitate the harmonization necessary to prevent regulatory fragmentation, coordinated to entities such as the International Medical Device Regulation Forum and the Global Initiative for AI for Health from WHO, the ITU, and the WIPO.
Thank you, Secretary Haddad. And I think you've spoken a little bit to Brazil's real direction around regulation, really seeking to develop this regulation just in light of the leadership that you've shown at the regional and the global level. I want to sort of pivot and talk a little bit about the computational challenges I think that exist. We know that Brazil has many academic institutions that have been really at the cutting edge around this work, but we know that there is a computational challenge and there's research that isn't happening, and that's really critically important. And so on that front, how do you see the government of Brazil thinking about this type of research that's necessary and part of the foundational infrastructure, just to build off of your earlier comments?
Well, this is very important. And we know that we don't have a very equitable distribution of the researchers and the experts in AI around the world. There is a imbalance on that, but Brazil is working hard mostly with public institutions, the Ministry of Health, the Ministry of Education, the Ministry of Science and Technology, and our network of public universities. For instance, here in Bahia, Salvador, we have the Fiocruz Foundation and the Federal University of Bahia, and we have SIDAX, which has been founded by Professor Mauricio Barreto, which has been working in very important research involving AI applied to epidemiology studies, to multi-level, multi-layers data sets, and with important achievements. And it's important that we keep on investing on that and addressing the complex nature of AI, especially non-deterministic technologies like large language models, challenges current regulatory assumptions that are based on deterministic outcomes. To navigate these complexities, we need a collaborative approach that combines the expertise of academic research and also regulators. Initiatives like the Centers of Excellence in Regulatory Science and Innovation in the UK and USA provide valuable lessons that can be adapted and applied not only in Brazil, but across Latin America and other countries. We believe that G20 could support the establishment of cooperative framework where both global and regional efforts in regulatory science can be synchronized to benefit all involved in ensuring safe and effective integration of AI technologies.
Thank you. Thank you. And just in terms of that South-to-South collaboration, I think you've mentioned some of the US and the UK and the work that's being done. How do you see opportunities for sort of the South-to-South collaboration in this area of artificial intelligence?
That's why we're working on G20, because we want to strengthen the South-to-South collaboration. We think it's very, very important. And with G20, we have this opportunity to amplify and support the South, the global South, let's say.
Absolutely. And I like that, the global South, because it in fact is. So just in terms of like closing comments, Secretary Haddad, what would you like to leave us with? Any final thoughts, something for us to consider in the deliberations for the rest of this week as we're together?
Well, I think that as new technologies arise, AI it's a very challenging one right now for us, because we are in the process of understanding how it functions and all this potential, but also the risks in its use. So it's important that we work collaboratively together and with responsibility, especially when we think about ethical use of AI, and that we think about the purposes. We should keep on working on equitable an equitable way to develop our and strengthen our health systems in an approach of universal access and public access. And so we hope we can use AI in this direction and collaboratively.
Thank you, Secretary Haddad. Please join me in congratulating and thanking the Secretary.
As I turn my pieces of paper to make sure I get myself to the right place, I do want to take a second to reflect on what just happened, because as an academic who spent their entire career trying to talk about regulatory science for AI, to hear the Secretary for Digital Health from Brazil talk about it as a potential priority for the G20, it's hard to find the words to go, maybe we just did it. But next, it's often hard as we come to global gatherings like this for us to find ways to anchor ourselves in what is happening at the last mile. What is the innovation that we are talking about helping to support? And to help us ground ourselves in that reality, I want to introduce Zamir Bray, who's been with the Gates Foundation since 2015, serving in roles focused on accelerating the use of new tools and technologies for global health development and digital inclusion. Zamir now leads the strategic coordination of the Foundation's approach to equitable and safe use of AI. And with the establishment of that internal AI task force, they're really trying to represent the breadth of the Foundation's focus areas. What Zamir is going to do in a moment is introduce one of the Grand Challenge grantees of the Gates Foundation to talk about the work that she's been doing in applying AI in healthcare.
I'm really excited to be part of this discussion representing the Gates Foundation, alongside some of our super grantees who have done an incredible job over the last few months, and you'll hear from them today. I do want to emphasize that the examples you'll see today really take a needs-based approach to developing AI tools. And each of the examples tie back to a very real need that was identified in the communities and countries that the scientists, innovators are located in. And they connect back to a real shortage of either staff, healthcare worker shortages, barriers around massive infrastructure costs like EMRs, or the need to be able to have a safe, trusting relationship on a very sensitive topic like sexual and reproductive health. At the Bill and Melinda Gates Foundation, we strongly believe that AI has the potential to reduce inequality in a number of ways, but only if we enable an intentional, thoughtful exploration that is led by local scientists and technologists. We have supported a cohort of 50 grantees across 17 low and middle income countries who are doing remarkable work to test the appropriateness, accuracy, utility, and feasibility of using large language models in LMICs. This combats a shiny tool phenomena and gold rush that is not sufficiently focused on generating evidence on what is safe, accurate, and appropriate. As the Foundation, we will continue to make more investment in developing appropriate benchmarks that help decision makers, policymakers, differentiate between good, bad, and dare I say ugly in this rapidly evolving AI for health space. We will only achieve this through partnerships with research institutions, technologists, communities, and critical agencies and platforms such as this one. 12 months ago, we were all speaking about the art of the possible. Today, we have the opportunity to shift gears to real-world applications in controlled settings, where the benefit is becoming clear and inspiring us to double down on our collective efforts. I'm confident that in the next 12 months, we will be able to celebrate some early wins using AI to reduce inequality and reconvene at this forum. It's a real pleasure for me to introduce a change maker, a pioneer in the field, Mariam Mustafa, who is the director of the Saida Wahid Gender Center, the Gender and Technology Research Cluster, and assistant professor at the Department of Computer Science at Lahore University of Management Sciences in Pakistan. Mariam's work focuses on leveraging novel technologies to solve some of the most critical challenges in the global south. She's also the co-founder of Awaz-e-Sahat, a voice-enabled mobile phone-based conversational AI assistant designed for maternal healthcare workers in Pakistan to create and manage electronic medical records and support diagnostics. Mariam also represents a little bit of the secret sauce that combines a deep understanding of technological capability working closely with healthcare workers on the front line.
Thank you so much, Zamir, for that lovely introduction. It's both an honor and a pressing necessity for me to address you today on the critical issue of maternal health in Pakistan, the potential for AI to revolutionize maternal health care in low-resource contexts, but also to talk about the associated risks and challenges of these technologies. Despite significant strides in global healthcare, Pakistan's maternal mortality ratio remains alarmingly high due to a confluence of interrelated factors. Foremost among these, as Amir has also mentioned, is the inadequate access to quality healthcare services, particularly in rural and underserved areas where facilities are often under-resourced and understaffed. What this effectively means is mothers dying from entirely preventable conditions like hypertension, anemia, and infections that go undiagnosed and unreported. One of the greatest challenges Pakistan is currently facing to improve maternal health outcomes is a lack of digital medical records, along with low-skilled birth attendants, which makes it challenging to provide accurate diagnosis, follow-up, or contextualized care, which is based not only on patient clinical medical history, but also socioeconomic context. What I mean by that, for example, is how much agency does a patient have in her own household? What are the chances that she will follow through on prescribed medications? Can she afford these medications? What is the distance from her home to the hospital? We know from prior work that all of this has a significant impact on maternal health outcomes. And access to data across different healthcare tiers would help better coordinate treatment and follow-up care of patients flagged with concerning symptoms. To address all of this, what we've done is we've created a simple mobile phone-based conversational AI assistant to make it easier to collect digital health records without the barriers of literacy, costs, time, training, and access to equipment. Health records that collect medical data, as well as the data on social determinants of health factors that affect pregnancy. Our system supports low-skilled healthcare workers by raising red flags based on the collected data to better inform decisions and improve patient outcomes. The system consists of a mobile app that records healthcare workers' audio recordings of medical data in the local language, Urdu. This speech is then fed into an existing multilingual ASR to transcribe it to text. A text generation module then prompts a large language model with the transcribed text to create electronic medical records. An LLM-based feedback module then asks maternal health workers to verify the medical records and asks follow-up questions to ensure records are detailed and complete. The LLM then also raises red flags based on patient history and symptoms. The Awaaz-e-Sehat application has been deployed at a local not-for-profit hospital that primarily serves low-income households for approximately 5 to 6 months and has generated over 500 EMRs and has been used by 26 maternal healthcare workers. It has also generated over 600 red flags, like low fetal movement or intrauterine fetal demise, preeclampsia, and gestational diabetes as indicators, among others. This is the first system of its kind that we know of that is in place in the wild in Pakistan. Opportunities for improving maternal healthcare outcomes based on our system are significant, particularly for low-skilled maternal healthcare workers. In the current hospital setting, our system has been particularly useful for nurses and for junior doctors who have limited experience with maternal healthcare patients and who often miss early signs of trouble. As part of our current efforts to scale, we are expanding the application to small maternity homes and clinics with only midwives. Most of these clinics lack a mechanism for documenting patient history, even on paper. In 2 such facilities, currently, lady health workers are already using a redesigned version of our app without any incentives. However, what we found in our context is that there is also skepticism towards these new technologies. We found it is essential to ensure that AI tools are transparent in their decision-making processes and open to scrutiny. This is particularly important, as we know, in healthcare, where trust is paramount. I'd like to speak a little bit about some of the challenges we've faced. And one of the biggest challenges has been, especially in terms of scaling and equitable access, has been a lack of regional language support. Currently, we can only accommodate Urdu, which is one of many languages. There are no data sets that would allow us to replicate this, for example, for Pashto or Saraiki, which are predominantly spoken in less urban, more resource-constrained areas, limiting our application to urban centers. Another significant challenge has been one of infrastructure limitations. The cost of servers, cloud storage, and LLM tokens is a considerable barrier. Many healthcare facilities in Pakistan operate with limited budgets and cannot afford the high costs associated with implementing and maintaining advanced AI systems. On a last challenge, I mean, one of the bigger challenges broadly, I think that Pakistan faces is one of regulatory framework, where we're not fully equipped to handle the nuances of AI in healthcare. This has the potential to create legal uncertainties regarding the use of AI tools, particularly of data privacy and patient consent. We believe our system is a first vital step to leveraging AI tools to improving maternal health outcomes on low-resource, marginalized communities to deliver equitable, high-quality care to expecting mothers. Thank you for the opportunity to speak at this forum.
Thanks very much, Mariam. And you will notice that Mariam and her team are focused on the solution that has the potential to completely transform and reduce the need for traditional, massive, super expensive EMRs that can take many years to roll out and have had little success in low and middle income countries. Now, I want you to just pause for a second and imagine the impact of the solution. A real-time, voice-based assistant available to healthcare workers across the globe, designed in a way to provide an ultra-low-cost electronic medical record and a conversational AI agent focused on enhancing the quality of care and ultimately saving lives. I'm sure you will all agree we have a lot to look forward to with the potential of AI.
I think it's those kinds of stories that give us a sense for why we're here and what we can achieve by working together to help regulate this technology more effectively. Next up, we've already heard about the leadership that the United States has shown in this space, and we're privileged to be joined by Adele Wagman, who is the Senior Digital Health Advisor at USAID's Bureau for Global Health, seated in the Center for Innovation and Impact. Adele is co-author of USAID's Digital Health Vision, the agency's first dedicated policy guidance for investments in the health sector, digital technologies, and data systems that support country programs. She authored and edited reports on the trends at the intersection of digital technologies and international development, including fighting Ebola with information, learning from the use of data, information, and digital technologies in the West African Ebola outbreak response, and Disaster Relief 2.0. The former was actually the document that led to the inception of what is Digital Square, recognizing that we needed a less fragmented digital health ecosystem. Adele, stage is yours.
Thank you. Okay, great. Can you all hear me okay? Excellent. Thank you very much. Thank you, Bilal, for that wonderful introduction. And thank you to our host, the government of Brazil, as well as to Secretary Haddad, including for the introduction you have planned for us to Brazil's history and culture. We appreciate that. Thanks also to the organizers of this event. You see their logos here on this slide for arranging this timely discussion. So by now, we've all heard about how artificial intelligence will revolutionize the health sector. And we hear stories like Miriam's that we just listened to, and they feel like there's solid evidence for this transformation now already being well underway. We're seeing people using AI to support trend analysis and decision-making, from genomics and drug discovery, and diagnosis to disease surveillance. AI-powered digital therapeutics are offering chatbots, health coaching, and supporting patient interactions. USAID is deploying a variety of AI health tools with its partner countries. One example is in Vietnam, which has one of the world's highest burdens of tuberculosis. We're working with the government there to roll out an AI-powered tool that supports TB screening. This AI-based software can instantly read chest X-rays, supporting radiologists in providing same-day TB screening and diagnosis. To ensure the accuracy of these results, patients receiving a positive diagnosis are then sent for molecular testing before beginning treatment. Key to this project's success is close partnership with the government, with the health workers on the front lines using these tools, and strong implementation and technology partnerships, as well as the availability of WHO guidelines recommending computer-assisted detection software to support TB screening, which gives countries confidence to bring these tools to bear. USAID is leveraging a range of artificial intelligence tools in its health programs, from machine learning to generative AI. The USAID-funded Epidemia project, which you see a picture of here, is a machine learning model that couples disease surveillance data with climatic variables, including rainfall and land surface temperature, to create a malaria early warning system. Health partners in Ethiopia have piloted this system to inform resource allocation in epidemic-prone areas of the country. In Eswatini, we're working with partners to explore generative AI's speech-to-text models to support health workers' clinical documentation and monitoring and evaluation reporting. So we're here to discuss equitable AI, and I think in that regard, it's important that we talk about the very real barriers facing AI's equitable access and use. All digital technologies face barriers impacting their accessibility. Yet, unlike previous generations of digital technologies, AI and generative AI in particular face an additional layer of limitations and risks. Generative AI, as we know, requires high volumes of limited resources, including energy, compute power, trained data scientists, and high-quality data. Generative AI can also pose new risks. It faces persistent challenges with hallucinations, with serious consequences in a medical or public health context. It can also introduce risks generated through the opacity of the technology's internal decision-making logic, its proclivity toward bias introduced by training data or algorithm design, or by a lack of users' understanding and informed consent about the ways in which AI-generated data and metadata might be used. These limitations and risks are particularly acute in the context of healthcare, with its highly sensitive data, and in developing country health sectors, where resources like high-quality data may be more scarce, and therefore the impact of bias as a result of the scarcity more pronounced. Globally, a number of actors have produced a variety of AI ethical and governance frameworks, yet nearly across the board, regulatory environments are outpaced by the speed of technological innovation. In developing countries, patient privacy and security may face risks posed by limited regulatory frameworks, specifically addressing AI and healthcare, as well as nascent enforcement infrastructure. To reduce these barriers to equitable AI for health access and use, governments, global health funders, and their development partners need to work together to clearly identify these and other risks and build collaborative plans to address them, including through a shared research agenda. This dedicated effort, delivered through partnership, is critical to enabling strong regulatory environments that encourage responsible AI innovation, as well as to learn together from what works and what doesn't. The US government has made a commitment to responsibly harnessing the potential of AI while actively seeking to mitigate risks. In October of 2023, the White House issued an executive order on artificial intelligence, directing sweeping actions, including to strengthen AI safety and security, protect Americans' privacy, and advance equity and civil rights, among others. This March, the Office of Management and Budget, or OMB, issued the first government-wide policy on responsible AI to address AI risks, expand AI transparency, advance responsible AI innovation, grow the AI workforce, and strengthen AI governance. This April, the US National Institute of Standard and Technology, or NIST, released a companion piece to its NIST AI Risk Management Framework, dedicated to helping organizations identify and manage unique risks posed by generative AI. So this is a space that's evolving incredibly rapidly, as we know. Building off of the USAID NIST management framework, building off of the NIST AI Risk Management Framework, USAID is creating an AI global development playbook to crosswalk the social, technical, economic, governance, human rights, and security contexts of AI use beyond United States borders. USAID is also working to assess and advance equitable uses of AI through an Equitable AI Challenge, investing in innovative approaches to identify and address gender biases within AI systems. USAID also supports the Global Index on Responsible AI, a measurement tool being developed by the African Observatory on Responsible AI to track this progress in 138 countries. Guided by its AI action plan, USAID's programmatic AI work is led by 3 broad actions: committing to responsible AI in our development programming, strengthening digital ecosystems to support responsible use of AI, and partnering to shape a responsible global AI agenda. At USAID, as we consider responsible AI for health, we see 3 primary opportunities around which we would welcome further engagement and dialogue. These are to support country health sector digital ecosystems, including especially regulatory environments, establishing AI for health benchmarks, testing protocols, and a shared research agenda, and prioritizing equity in AI model creation and deployment. First, as we've learned repeatedly over 2 decades of investments in digital health, the strength of a country's digital ecosystem is at least as important as the technology itself. We've invested a lot of time as a community documenting these lessons about the interplay of digital technologies and their use environments in developing countries, capturing these insights in the principles for digital development and the principles of donor alignment for digital health, which you see here, also referred to as the digital investment principles. The good practice reflected in these principles provides important context for thinking about how the G20 can best approach AI regulation to support equitable access. Harnessing AI to improve equitable health outcomes requires strong country digital and data governance, a skilled workforce, including health workers fluent in the use of AI tools, and empowered health institutions whose policies and practices are adapted to enable new workflows and decision-making processes based on AI-generated insights. Second, we need to establish benchmarks and testing protocols that will help us understand what constitutes a good, unbiased, or high-quality AI use in the health sector, and a shared research agenda to undertake these assessments and share their results. We need publicly accessible benchmarks and standing testing protocols that are relevant to a diverse array of health use cases and settings to help promote trust and ensure safety for all. We also need a shared research agenda focused on the intersection of AI and health to assess AI's effectiveness and feasibility across healthcare use cases and to refine approaches to benchmarking, testing, and auditing. A common research agenda, together with shared knowledge and good practice, collaborative platforms for data access and sharing, and a continuously updated evidence base is critical to unlocking the full benefit of AI for health. Last, but certainly not least, we need to ensure that those involved in creating and adopting AI technologies represent the diversity of its users. If we're serious about equity, we need to ensure that the talented data scientists from around the world, and especially in low and middle income countries, can push this work forward to help address the limitations in existing data sets and AI models. Beyond this investment in talent, equitable AI needs investments in data and compute that are broadly representative of and can effectively reach people in all parts of the world, not just in high-income countries. Taken together, we believe these opportunities can help ensure we're building safe, trustworthy, and equitable AI systems for health. In conclusion, there's every sign that AI will continue to provide more ways to connect people and communities with access to health information and services they need to live healthy and productive lives. Yet generating this future will need more than the right prompt. Harnessing and promoting the benefits of AI for health requires multi-stakeholder collaboration, leveraging existing collaborations such as those housed at WHO to tap into the expertise of local communities, civil society, governments in the private sector, among others, to navigate barriers and risks. The G20 is well positioned to highlight this need and to organize activities to help strengthen country regulatory and enabling environments for health AI. This direct engagement and partnership between multilateral entities, global health organizations, and developing country governments can enable innovation to flourish while ensuring that the potential for AI in health is met with the necessary guardrails to ensure its ethical, accessible, and equitable use. Thank you.
I'm much shorter than Adele. Adele, thank you so much for those remarks. And the thing I really want to call out is the work that NIST has been doing that you highlighted. I think it's impressive to see how quickly the American policymaking establishment has responded and demonstrated that we can build the safeguards as quickly as we innovate, right? We do not need to sacrifice innovation for safety. Our next segment of today's session is a panel that hopefully takes us a little bit more broadly than what we've been, or takes our focus a little bit more broad than what we've been focusing on up until now, where largely we've been talking about the use of AI for healthcare service delivery. But we've seen real strides taken in how AI can support science and health research. And to lead that panel, we have Tarek Kokar. Tarek leads a multidisciplinary team of data and technology experts who shape and fund data science initiatives to support the mission of the Wellcome Trust. Science and health research to solve the urgent challenges facing everyone today. The team focuses on ensuring that technologies that underpin health and science research are effective, well-governed, and equitable. And I'm going to hand over to him to introduce the rest of the panel. Tarek, over to you.
Good afternoon, everyone. I don't know if you can see us yet. I can sort of see a big screen with a G20 logo on it. Okay, that looks more promising. And can everyone hear us okay? Can I get a wave or a thumbs up? All right, I see a wave. Fantastic. Hi, everyone. Good afternoon to folks in Brazil. I'm Tarek Kokar. For reference, I'm much taller than Bilal. So if you wanted to imagine where the microphone would be, think more Adele height. And as Bilal said, I'm the head of data for science and health at the Wellcome Trust. It's my pleasure to be hosting this panel discussion. We're joined by three experts who are going to be highlighting their experience of how AI is being used across the areas of science and health research and exploring some of the challenges to delivering more policy relevant insight. So I've actually been here in Geneva for the ITU AI for Good Summit for the last few days. And I know some brave people actually flew from Geneva straight over to you. But one thing I noticed is there's a tendency in the AI discourse to center attention on technology and on technology companies and all the headline grabbing sort of successes and failures. But as we know, and we've heard earlier from Adele, from Mariam and others, the reality of how new technologies are adopted, adapted and incorporated into health products and services that benefit people in varied communities is complex, it's nuanced, and it's often not in the spotlight. So please let me introduce the following fantastic individuals we are spotlighting. And let me start with Agnes. So Agnes Kiraga is the head of data science at the African Population and Health Research Center in Nairobi, Kenya. Her focus is on building the capacity of data science, promoting responsible data sharing, and increasing data use for evidence generation to address population health challenges in Africa. Thank you for joining us, Agnes. Next, we have Dr. Vin Bui, who is a senior lecturer and an enthusiastic researcher at Southern Cross University, Australia. His research focuses on applied computing with applications in healthcare, tourism, and environmental sustainability. He secured over $10 million in research funding and published 30 peer-reviewed articles in the above areas of research. actively involved in community engagement. Dr. Bowie participates in various events and symposiums and holds professional memberships in the Australian Computer Society and the IEEE Computer Society. He's currently leading the development of a software system aimed at predicting and controlling dengue outbreaks as part of an ambitious project to eradicate dengue in the Mekong Delta of Vietnam. Welcome. And lastly, we have Dr. Melanie Saville, who's Path's Chief Scientific Officer. She leads Path's Product Development Division, which includes a global team dedicated to the development, introduction, and scale of vaccines, medical devices, and diagnostics. Dr. Saville is a distinguished physician specializing in virology with more than 2 decades of experience developing and licensing vaccines for global use. Her contributions over the past 20 years have included the development of vaccines for seasonal and pandemic influenza, as well as pediatric combinations and vaccines against rabies, Japanese encephalitis, dengue, Ebola, and SARS-CoV-2. Welcome to you as well. So I'm just going to dive straight into questions, if I can. Maybe I'll start with Agnes. So Agnes, one piece of work we're really excited about at Wellcome to be supporting is the Data Science Without Borders project. So other than having a very cool name, can you tell us a little about the project and the role of AI in achieving your intended impact?
Yeah, thank you, Tarek, and to the organizers for inviting me to this very important meeting. And I'm excited because I represent the African Population Health Research Center, which is a think tank with footprint in about 40 countries in Africa. And through that process, we quickly realized that there's diversity in the continent in terms of data maturity, in terms of the skill set that's available on the continent, the compute across the continent supports the use of AI and other initiatives around data. So with that backdrop, we then developed a very interesting concept called Data Science Without Borders to leverage different countries that have forged their way into the use of data more effectively and the harnessing of artificial intelligence for decision-making, and design this project that's going to be conducted in 3 African pathfinders, which is Cameroon, Senegal, and Ethiopia, which are quite diverse in terms of their data maturity and infrastructure. And then with a project led in Nairobi, which is, might be more invested in terms of data structures, is going to coordinate this project to ensure that we work with the countries themselves to improve their data systems. We want to do a lot of capacity building in the different teams where this data are collected. And then, of course, we want to leverage LLMs and no-code platforms to help us analyze this vast amount of data that is coming in from these 3 African countries. And this working in partnership with the Alan Turing Institute in the UK and London School of Hygiene and Tropical Medicine, CoData, which really works with issues around fairness of data and accessibility, and of course governed by the Africa CDC. So what we've realized is that there's a lot of potential to leverage AI in the continent. But as we do this, the continent has to leapfrog because there's a lot of investments and we can't keep being left because of the different challenges. We've realized issues around the lack of compute, the lack of cloud access. We've talked about things like data centers. If you look at the African continent and the investment that's going on in there, we have about 100 data centers, and these are largely predetermined or located in the southern part of Africa, and the rest remains under-resourced in terms of compute. But what is also coming out clearly is the governance. If you look at the African continent, about 36 countries have different data protection laws, and this makes it even more challenging to move data from one phase to the other to allow the effective use of AI. So with this project, we have the new technologies around federated platforms for sharing data, equipping the data scientists on the continent, even equipping people to use open software. If you look at the statistics, there's about 1 in 100,000 Africans who have actually used GitHub. There's a lot of capacity to build in the continent. We need to make the data sets available and then be able to use these facilities and data sets to help us address different health challenges coming in from hospitals, from research institutions working in HIV and TB and other kinds of diseases. If we can then leverage this Data Science Without Borders project for the next 3 years to help us address the key challenges around compute, capacity building, and facilities that are going to help us empower AI as a tool to create evidence and help us create information that is going to speak to the African agenda, which is largely driven by the AU 2063 agenda, which ensures that most of the decisions around public health are actually driven by data. So we are interested in this project. We look forward to the 3 years of engagement, the diversity, and hopefully it was to other African make Africa, at least saying some level of minority, able to comfortably use AI to solve their different health challenges. It's my internet and still. All right, I'll stop here. My internet is shaking.
No, I think the internet timed that perfectly, and that was a super overview of data science without borders. We'll come back to you for a bit more of a dive into that. But switching continents for a second, Vin, I'm wondering if you can tell us a bit more about the work you're doing on infectious disease forecasting.
Thank you, Tariq, and good afternoon, everyone, and good morning, actually, from Australia. So, first of all, I want to thank the Wellcome Trust for the opportunities and to share our work with the public audience in this meaningful event. Well, I want to begin by explaining very briefly about AI and machine learning. AI, artificial intelligence, or machine learning in particular, right, is a type of computer algorithms that can learn from past experience using historical data. Now, the ability to learn make the algorithms intelligent. For example, machine learning model can be trained to forecast dengue outbreaks by learning from past incident data, along with disease transmissions, environmental and socio-economic factors. Machine learning models can learn temporal patterns in the disease transmissions dynamics to predict the future trajectory of dengue spread. And machine learning model can learn to identify critical factors that contribute to the risk of dengue outbreaks. However, there's many challenges in forecasting infectious disease, such as dengue outbreaks. Now, the third challenge that we're facing is the data quality and availability. Now, in many regions, especially in developing countries, we face incomplete and underreported data due to limited healthcare access and infrastructures. Now, for example, Brito index, an important factor for forecasting dengue outbreak, right, was collected only monthly in Vietnam and only in two districts in a province. In addition to that, inconsistent data collections and validations methods further complicate the reliabilities of prediction models. Now, the second challenge that we have is the environmental variabilities. Infectious disease such as dengue is heavily influenced by the weather conditions, such as temperatures, rainfall, and humidity, which have a very high degrees of uncertainty, obviously, right? Especially under the climate change conditions. Additionally, urbanization and changes in land use affect mosquito habitats and making forecasting more difficult. The third challenge that we're facing is a complex transmission dynamics. The behavior of Aedes mosquitoes is the primary vectors of dengue, influenced by climate, human activities, and mosquito control measures. Human movements and migrations also play a critical role in spreading this disease to the new area. The fourth challenge we're facing is the socioeconomic factors. The high population densities can facilitate the spread of dengue, but the socioeconomic status affects the exposure of risk and health access. Public health infrastructures and the effectiveness of interventions vary, impacting the dynamics of the outbreaks. The fifth challenge is the temporary variabilities. The dengue outbreaks often show a seasonal patterns, but this can change yearly due to environmental conditions, and predicting the timing and magnitudes of epidemic peaks remains a big challenge for us. Last but not least is the modeling complexities. Accurate parameter estimations and model validation are essential, but it's challenging due to the cost, computational, and other barriers. So how are we addressing using AI to address these challenges? So some of the things that we are doing in this project, The first things we apply multi-source data analysis, such as weather data, population density, travel patterns, and social media activities to improve the accuracies of the disease forecast. Machine learning is very useful for learning patterns and identify important features from these combined data sets. For example, our machine learning algorithms show that this could be a strong correlations between poverty and dengue outbreaks. We also integrating geographic information system with machine learning to analyze spatial data and predict hotspot for dengue outbreaks that allow us to have more targeted interventions. Our machine learning model will learn correlations and the key factors such as population density, location of populated landmarks, such as school, hospital, and markets, and the dengue outbreaks. We are also using machine learning to complement traditional approaches, such as to estimate parameters of dengue risk assessment models. So that's some of the way that we use machine learning in our current projects. It's important to know that artificial and machine learning in particular is a very powerful tool for solving very complex problems, such as infectious disease forecast, but it's not a silver bullet. The data quality and availability remain the most serious challenge in forecasting infectious disease, including dengue. And therefore, alongside with the developing more accurate prediction model, we are helping Vietnamese government to improve the infectious disease surveillance system to address the data quality and availability in the future. That's what we'll be doing at the moment. Thank you.
Fantastic. Thanks so much, Vin. And we'll come back to you to maybe dig into a couple of those challenges and opportunities in a second. Turning to you, Melanie, I know you've been involved for much of your career in vaccine development, both before and during PATH. And I'm curious to see how, from your perspective, AI impacted the vaccine development sector, and how in particular do you think that impact is relevant in low resource settings?
And thank you, Tarek. And yes, so obviously I'm approaching this as a virologist and physician, not as a technical expert, but what we are really seeing in the field of vaccine development is that there is a huge potential for AI. And maybe I'll just focus on two of the key areas where we are seeing a lot of activity and potential progress. So really the first one is AI-assisted vaccine design, so the immunogen design of a vaccine. And as we've seen other technologies moving forward, there's now a vast amount of data, genetic data, molecular data, and cellular data that really can input into our understanding of pathogens, viruses, bacteria, that can allow us through computational design to really design the type of immunogen that you're looking for. So if you want a vaccine that produces antibodies, thinking about how you can use all of that data and computational design to develop a vaccine that will target antibodies, or targeting cellular responses as an example. You can also think of integrating important elements that might be important to low and middle income countries, that might mean that the vaccine is more amenable to cold chain, more reasonable cold chain, or easier to manufacture. So it's a huge area, and I can give an example actually from a little bit from my previous life at CEPI. CEPI actually have invested quite a lot in computational design for vaccines through what they call Disease X and the 100-day mission. So really looking broadly across virus families, what are the immunogens that you would want in a vaccine, and getting a library of exemplars together. As well as that computational design, it's really important that you then have the high throughput in vitro, in vivo assays and techniques to evaluate those computational designs, and then have that feedback loop to continue to improve the design. So on its own, it can't do everything, but it's potential for really potentially producing better vaccine designs and faster. The second piece where there is a lot of research is on clinical trial management, and this is such as AI-assisted design, recruitment of subjects, adherence to protocol, data cleaning, analysis, summarization, writing reports. And all of these elements can really give us the opportunity to have a number of efficiencies. And this is efficiencies both in cost, which is important for diseases for low and middle income countries, but in time, really potentially reducing the time of development substantially if you add all of these pieces together incrementally. So a lot of potential there. So I'll leave it at that at this point, because they're really the two main areas, but actually the areas are vast, to be honest, and there's a lot of work in the space.
Fantastic. Thanks, Melanie. And maybe just to add an anecdote from our universe at Wellcome, just as it's important to think about the high throughput biology for validating the things that these models are spitting out. Increasingly, people are investing in high throughput biology to generate data to put into new models, because many of the general purpose models, while they're great on kind of in-sample performance, but they get kind of wonky when you start trying to do anything out of sample. Fantastic. So let's go for a round of follow-up questions. So maybe this is both for Agnes and Vin. We've covered quite a bit of ground. We've gone from sort of clinical AI and sort of capacity building, and then down into sort of cell biology. It's clear there's lots of opportunities for impact here. But I'm curious, I mean, you mentioned some of them earlier, but can you just dig into maybe one or two of the challenges that you've found working in low and middle income countries, and just sort of unpack them a little bit for us, and then tell us how you're tackling them. Agnes, I'll start with you, and then I'll go to Vin.
Yes. So I think one of somebody mentioned earlier, one of the challenges that drive the lack of application of AI, I broadly I'll put them in three. But the first is the quality of the data. But even before you get to the quality, the sharing of the data. We've seen a study that was interesting. It mentioned something very funny, not interesting. It said data moves at the speed of trust. And without trust and without the data controllers knowing what you're going to use their data for, we then can't get to the last mile of using AI. So we have a lot of researchers, in fact, about 75% of researchers, when asked, or data producers, you have the data set, why don't you get this data set pulled to a bigger resource where we can use AI and different machine learning tools to help us address a question which might be well represented with different data sets? There's a lot of resistance for many reasons. I mean, some, the unknown of what the data will be used like, and then issues around how do I even share these data sets? But the second is around the quality. And I think Vin mentioned it, the quality of the data coming in from, is it shaky, or should I remove the video? Some of the data coming in from the different member states in Africa it faces a lot of data quality issues. You spend a lot of time trying to get a usable data set, and even when it's available, it has different, the representativeness of where the data is collected, and then thereafter it again dives into the issues around how usable is going to be used, what are the training data sets you're going to use here and there. But I think what we are going to see in the nearest future with the different platforms that are being available, federated platforms where researchers now have the confidence to have a secure environment where their data can be housed, and then leveraging the AI tools to analyze different collaborative questions in an environment that's secure, which will still need a lot of compute and the skill set on the continent to even develop these trusted or secure data environments. It's one challenge, but I think the issue again is also governance, and I think I've mentioned this again. Moving data from Senegal to Cameroon for you to do a collaborative analysis between the two countries takes a lot of effort, because the data sharing in one country and is not exactly the data protection laws vary. So in our Pathfinder projects, we are going to ensure that we leverage the existing platforms. We leveraging platforms and policies on the continent to help us move data from one place to the other. And then in Senegal, what we're going to do and leveraging some of the tools there is to use the clinical support, tools that can help us maybe do early prediction of poor healthcare outcomes in some of the hospital settings, and then leverage the tools that we'll have in one country to be able to expand this in other countries. And maybe with that, we'll get more buy-in on the continent. But in the general scheme of things, there's a lot of interest to leverage machine learning tools, and some of the platforms we're developing in-house should be able to quickly be adopted by different researchers or data users. And then that way we can comfortably be on a better radar of getting evidence from different AI tools. It's a long journey, but we are starting, and I'm hoping that in the next 3 years we'll be at a better stage in terms of design.
Fantastic. Thanks, Agnes. And maybe if I can just follow up on one point. I mean, you talk about the idea of effectively trusted research environments where data are in one place and researchers come to the data to do their analysis. I'm curious, in your experience working where you do, is that genuinely a way of getting over the trust issue, or is that like that's a cool technical solution that hopefully you feel people will get excited by?
I think once we understand it's the power of a secure data environment, I know we've met with the Open Safely who have had enormous steps in using these secure environments, and looking at what potential they have, it will be a step towards going around test issues. Because if you have an environment and the researchers know that their data is being used for this particular reason, you can then also have access to this large collaborative safe space where you can post your data sets, and then the aggregate results are returned back to you, and the data remains preserved in in a confidential setting. I think it's going to be a good step towards increasing data sharing on the continent. So it's not more of a technical issue, but I think if we also go around the added benefits and that then it's going to be a good step towards the nuances around data sharing. But of course, it's going to need a lot of investment. A secure data environment is heavily computational. The skill sets to run this on the continent needs to be empowered, and a lot of capacity building in there. But if successful, it will be a good step towards data sharing.
Fantastic. Thanks, Agnes. We lost your audio a little bit in the middle, but it kind of came back in force at the end. So we caught the headlines. Vin, I wonder if I can turn to you for the same kind of questions. I'd love to just hear you dig into one or two of those challenges a bit more.
All right. Thanks, Tarek. Okay, so I think when we're talking about obviously machine learning's data qualities and availability is one of the big challenges, and especially in the projects that we're doing in Vietnam to develop a model to predict dengue. For example, dengue cases, the way dengue cases are recorded in Vietnam very, very differently from region to region. So almost every province actually has its own kind of tools and software to record dengue, and there's no standard actually across the country. So as a result, for example, one patient's moving from one place to another place will be recorded multiple times in the systems. And also, you see that there will be a difference between the diagnostics, like when they enter the, when they come to the hospital, they will have some sort of initial diagnostic, and then after all the tests and tests come back, they will likely to have a different diagnostic to, to disease they have. But in different regions, they have different way of recording that. In some regions, they will record the symptoms or, the predictions where they come to the hospital, and then some already recorded when they come out from hospital. And that actually impact the way the way governments and the CDCs actually record the number of cases. And that's leading to the fact that, the data that we use to pretty much like the historical data to train our model is not accurate. So we have to fix that problem. Another problem is in Vietnam, the administrative boundaries of of the regions. They keep changing over time very quickly, So for example, in this year, 2024, they expect to change the administrative boundaries of about 60 provinces in Vietnam. And when they change the administrative boundaries, they, like all the data recorded, for example, patients' address will be changed. And the dengue and a lot of other infectious diseases, they are very sensitive to temporal and spatial kind of real correlations. And when they change the administrative boundaries, literally they introduce a patient that used to belong to one district, for example, now actually will become like in another district. And as a part of that, like all the data that we use, or all the statistics of the data that we use will need to be updated based on the new boundaries. So to address those challenges, like we have developed new tools that incorporate the geographical information systems. In particular, like we try to use some service called geocoding to actually allow the healthcare people to actually map the address of patients to the physical address on the map. So that allows us to actually trace and build a data set of patients with their physical geographical locations precisely, without like worrying about the change of the administrative boundaries. So that will help us to actually create a higher quality of data set in terms of the dengue cases. So that's one of the example of the challenge that we're facing, and the way we try to fix it. And another problem that we have is because they're using different software, so there's no standard to actually interact with the software to actually get the data automatically. So we have to really work with the Ministry of Health of Vietnam to identify the companies actually to develop those software, and then work directly with them to actually introduce a standard so that we can really extract the data automatically from the systems and update, like all the historical data that we can get and we can use for the models. Also, another challenge we have is not just the data, but like the skill. For example, in the current model that we try to develop won't allow us to predict dengue in one district, well, for example. But when you talk about intervention, then the district scale is still too big because of the lack of resources. So if you want to predict dengue, for example, to the commune level, which is one lowest level to the district one, then the data that available at the commune level almost like nothing. They recorded data mainly, like manually on papers, and then like there is no easy way to actually collect those data. So we have to use machine learning to actually not to learn directly from the data, but to actually learn the parameters or to help us to identify the critical factors that will likely to contribute to the risk model that we develop for the commune level. So it's mean that no machine, like because of the lack of data, we can't really build, like a machine learning model to directly forecast, for example, how many cases will be at a commune level. Instead, we have to use machine learning to actually predict the parameters of a risk assessment model that we can that later on can be used to really identify, like for example, what communes within a specific district were likely to have dengue, so that they can have more targeted interventions. So that's some of the challenge that we're facing, and then the way we work around to actually try to fix the problem. But I think probably in the longer futures, what we want to do is we want to give probably recommendations to the Ministry of Health of Vietnam to really develop a more standardized kind of infectious disease surveillance systems, so that they can have protocols and standard for all kind of data collections. And if they manage to have this kind of systematic collections of data, including not just the dengue cases, but all the surveillance data related, like Brito index, like household index, and etc. Also including, like the data from the micro-environmental kind of data, because, like we know that even though dengue has a seasonal kind of patterns, and it's quite sensitive to climate in general, but it's not really sensitive to the global one. It means that anything that we get the forecast from the global, from the, like from the larger scales perspective, doesn't seem to have a very closely impact to the outbreaks. So what we need is more kind of micro climate or micro environmental data, which cannot be easily collected using, like, for example, weather stations. So we need to develop probably a better approach to collect those data. So we can, and then once we have better data with the better qualities, I think we can develop a better model to predict dengue, like in the country.
Fantastic. Thanks so much, Vin. And I can deeply empathize with the subnational boundary stuff changing. It's just a nightmare. But I'm glad that we're building technology that reflects reality rather than trying to bend our reality to technology. Lastly, Melanie, I'm wondering if I can come to you. So switching the discussion more to the I suppose policy side of things. You've worked on policy at the national and international level, and I'm curious, just what's your take on, is AI having an impact on policy, and what's the route for these tools and technologies together?
Yeah, so first of all, I still think we're a long way away from trust of AI for things at the policy level. And I think it's already been mentioned, but there are some clear bottlenecks in the space in the context of data security, sovereignty, and access. And this was mentioned before, and these are key areas to be considering in the context of policy making. Certainly from a vaccine development perspective, I mean, we really have to think of regulation and the regulators. The regulators are learning as we are learning, actually. And we are seeing some divergence in the thinking by regulators in the use of AI or software as a medical device, as an example, in different regions and different countries. And I think it's probably important to think about how can we get, to a common set of understanding for the regulators across the world, I think will be really critical. I think the one piece of concern is relating to data sets and decision making, and there is more data in high-income countries than lower middle-income countries. We have to recognize that. And are decisions being made on the right data sets? What is the quality of the data around the decision making? And so with that in mind, you really need to think about encouraging all of the countries to build their data infrastructure and digital infrastructure to gather the data in their own populations. The data is only as good as the data sets that they come from. Other things that are important are some of these AI tools have lack of reproducibility. This reproducibility is absolutely key for a regulator. For a vaccine, you have to be able to have reproducible results. But maybe just to finish on, I think it's really important that there is open access to the AI tools for all. Again, otherwise we run the risk of inequity.
Fantastic. Thanks, Melanie. So we're just about at time, and I'm wondering if I can ask our panelists just to share like one idea you'd like the audience to leave with as they kind of go about their future work in AI for science and health. So let me start with Agnes. So what's the one thing you wanna leave people with?
The future of AI is we are in the future, and I think AI should be used across the whole pipeline of data, the whole value chain of data, from the time we define research questions to the data management to the data sharing, all the way up to its application in evidence and information generation, and its application to day-to-day challenges, at least across the world and also in the African ecosystem. We are going to have to embrace AI. We have to maneuver some of the challenges, but it's feasible, it's doable, and it's going to shape the public health and the whole ecosystem in the continent. So we are happy to collaborate and happy to partner in the bid to improving AI across the world. So I'm happy to listen in, and thank you for the opportunity.
Fantastic. AI for the whole value chain. Vin?
I think probably my message probably is about ethics of using AI. So, we know that AIs, especially generative AIs, have introduced a great challenge to not just everyone, but in particular the education sector. Because I'm from university, I know that's how challenging it is. Because now it's really very difficult to really assess students based on their quality of work, because we don't even know whether this piece of work generated by AI or is from the student. So teaching people about ethical use of AI is critical in my view. And obviously AI is going to change the world very quickly, rapidly. And but we know that AI learn from historical data. So if we keep overuse AI, we come to the point that we no longer be able to generate new data or new knowledge. It's my view.
Fantastic. Thanks. And Melanie, over to you.
Well, just to say, I think AI has huge potential, but we mustn't forget the use of humans to see what AI is doing and challenge and interpret and improve on the potential for AI in the future as part of many, many things that need to come together.
Brilliant. And if I may, like this has been a pleasure to host this discussion. It's been fantastic to hear from Vin, Melanie, and Agnes. And maybe the one idea I'll leave folks with is going back to what I said at the beginning around a lot of conversation centering on the technology industry. The technology industry right now is in a race to the top, right? Biggest models, fastest models that most people use. For us working in science and health, we want to be in a race to be useful. And that doesn't mean the biggest, the fastest, the flashiest thing. It's like figuring out how do these tools and technologies actually move the needle on issues that matter. So that's the idea I'd leave with. Forget race to the top, race to the useful. With that, thanks so much. It's been a pleasure, and over to whoever's taking over in the room. See you.
Thank you, everyone.
Thank you, Tarek, and thank you all. We heard a lot in that panel about the importance of data, digital infrastructure, and really I want to bring us back to Brazil to celebrate some of the success that you've had here that the Secretary mentioned slightly earlier with CDAX and Fiocruz. And so as our last little section in this session, I want to invite up Professor Alain Labrique, who many of you will be familiar with, the Director of the Department for Digital Health and Innovation at the World Health Organization. Until 2022, he was the Director of the Johns Hopkins University Global Health Initiative and Editor-in-Chief of the Oxford Digital Health Journal. He also chaired the first WHO Digital Health Guidelines Development Group, and you have, I'm sure, all heard him talk about the global initiative on digital health. Alain will be helping us to moderate a conversation with Professor Mauricio Barreto, the Emeritus University Professor at the Federal University of Bahia and Senior Investigator at Fiocruz. He was the founder and the head of the Center for Data and Knowledge Integration for Health CDAX, and is the co-director of the NIHR Global Health Research Unit on social and environmental determinants of health inequities. Mauricio has done a phenomenal amount of work, and I'd like to invite both of you up to the stage for a short conversation to share how that powerful investment in digital infrastructure allows us to unlock the opportunity of AI.
Oh. We get to sit in the comfy chairs. So I think it was good. We got to walk 6 meters and exercise ourselves. But I think when we transition to the closing, I'll ask you guys to jump up and exercise a little bit. So Mauricio, pleasure to have you here today. And I hope everyone else has really benefited from these rich conversation, some very insightful insights from different parts of the globe and from different perspectives. And I think that's what makes this kind of forum exciting. We get to hear from so many different perspectives. So many people may or may not be familiar with this world-leading informatics facility that you are leading here in Bahia. Can you explain to the audience a little bit what CDAX is?
Yeah, okay, Alan, thank you very much for the stay here in this conversation. Thank you to Bilal, to the invitation, and to the G20 organizers to invite me to be here. I'd like, before the question, I'd like to put two questions to contextualize all the development. One is in Brazil, there is a national health system. Now, this is a really very important thing. Brazil maybe is the only country that the constitution say that health is a right of every citizen and a state obligation. Now, this is established in our constitution, yeah, and the government want or not to have to complete and to achieve the constitutional right. Then health is a constitutional right in Brazil. Another thing is on data. Now, I was talk a lot on data. Brazil is a large country, as you know, yeah, with very large areas. But Brazil has a tradition to collect data, and health included health data. Now, this is a history. Yeah, PAHO have a very important role on that in Brazil and the other Latin America countries. Yeah, but also the fact that Brazil was a very centralized country. It's a democracy, a federative republic, but it's very centralized, and all these systems flow to central systems. Then in this context, I, as an epidemiologist, that use data all my life, the data is not something new for us. I think you are talking about digital world, but as a researcher, for a long time, you have been the digital world. Now you are talking now about the digitalization and in the health system, but in science, the digital perspective was always being part of our day-to-day activity. Then what's happening in CDAX that you use it with data, but in general, in health research, yeah, use a small set of data. You use some data collected, yeah, of a few people, and the maximum a few hundred or a few thousand people. Then in some moment, in my research program, and the other colleagues, you decide to move to another step based in experience, yeah, that you have been, or small experiences in some country like the Scandinavian countries, in UK, in Canada, in Australia, yeah, that Brazil, with this huge amount of data that the health system produced, why not to link this data into to give a step forward, yeah, to transform these results, yeah, in a great resource to produce knowledge useful to build it, to help the development of a health system. Then I think this was what moved CDAX. Then you start to have access to different set of data in the country. For example, in the time you have been shown a preliminary study on the impact of our cash transfer program yeah, on the infant mortality, yeah. And the minister at the time was a woman, a very bright woman, as our secretary, other people here. Yeah, Brazil have a very important woman that this is a really a big transformation in our society. And she was very nice to her to know that her program, yeah, have impact on poverty, but also have impact on health, yeah. Then she opened the opportunity was to use the original data, yeah. Then was the Cadastro Único is a kind of register that is used for everyone in Brazil that apply for a social program need to complete this, yeah. And as an epidemiologist, you are obsessed by data and by forms. Né? Then you collect this in our routine. Then, but it give you the opportunity to use millions of these forms. Yeah. Then you start to join this because they work in an administrative way. Then you take all the history of the system and put all one side by other. Now you have a cohort and you link all the data. The health, the Minister of Health give you as opportunity to access important health data, yeah, original data, identified data on mortality, births, and the others. Then you put this together and create a huge cohort. Then you denominate the 100 million cohort, Brazilian cohort, that now, in fact, in the moment, have 131 million people, yeah? Then is the biggest cohort in the world, yeah? People are used with 1,000, 100, 1,000. Now you have 100 million. On side of that, you create a birth cohort that now have 31 million births, yeah? Then give you a huge opportunity, yeah, to answer different questions with a very high level of generability, yeah, because it's a kind of data that you massively understand what's going on your question is put. You can answer a question that cover all the country, stratify data, analyze in different contexts, because there is a huge flexibility to explore that. And using very strict methods of research methods, data quality, and good research questions, and answer and decompose the data, because you don't have a sample limitation that is, as you know, is a huge problem. Anyone doing research is to break your sample to do stratification. Now, in our case, there is no limits of that. Then you can analyze in different way. Then in this context, that was born the 100 million.
I mean, it's an epidemiologist's dream, right? You not only have a strong denominator, but a massive numerator of outcomes. But 100 million or 135 million Brazilians in this cohort. How do you get there? What is the role of standards, and what were the early investments that Brazil made that allowed for you to build this massive cohort?
I think the first investment was data quality. This was crucial, because if you don't have good data, it's not good data. Bad data will generate bad garbage. If you want to have good data, you can. If you process well, you have a nice end. And then was this investment. But sure, you move from microcomputers that that as a researcher, I use doing analysis in microcomputers. Now you need to build complex systems with servers and things. Then this movement was very complex, yeah. But I think the most important is the regulatory movement. I think you created SIDAC 7 years ago. A few years later, it started in Brazil to be discussed the data protection law. The data protection law was a very important law that was approved in the parliament in 2018 and was in fact in action 2 years later. Then SIDAC have an important role on that at the end, at least to influencing the debate on the use of data for research, yeah, because the data protection law until there was around the other questions. Yeah, for example, the Twitters and the others resources, but very few on data for research. Then I think the experience of CDAX was very useful. And for example, the rapporteur of the law came to CDAX and say one morning, try to understand, And at the end, I don't say that we create that, but influence, I think so, that Brazil law have one chapter dedicated to public health research. Yeah, that was, I think this conversation was very important to the member of the parliament, that was the rapporteur, to think about that, and to say that you have good data, you have things, you have, if you keep it privacy, and use it to the common good, you must use the data that you have, to produce research. This was a very important step.
I think it's also, it would be obvious to see that the European health data space has benefited greatly or been inspired by the lessons learned from what you've done here in Brazil. So giving power and access to that much of a population to understand and gain insights on what's going on at the health level. Recently, I think you started to also try to integrate, as we heard from our last panel, multiple sources of information, including, say, weather and meteorologic data, and to really understand the multidimensionality of disease dynamics, et cetera. How has that process gone? Or any challenges or lessons learned?
Challenge. One point is that the data is important. Data is very classical. It's very, they use, everyone talk about data. Data can be used for everything, for different purpose. And in some moments, you are always interested in study climate effect. Why? Because you have a cohort that covers all the country. Brazil have different biomes, different climate. Is in process of climate change, very clear climate change, and a lot of events is happening in Brazil. But was very lucky because Wellcome Trust that at this time identify that Bilal was there. That's more. Identify that they can found a group in the world that can help to develop a platform to think. Then they give us opportunity to present a project. They give some money for us, and you started with a big challenge. One is to introduce all this meteorological, climatological world in our system. That is a very cultural process, to have people with different language, different things, different thoughts, but also with some specific challenge, how to combine climate data with the health data in a very large scale. Then this is a problem that you are a challenge that you are living the moment, because you started that it's not end of past year, then you have yet not sufficient solved all the problem, but you are in process to go to this important new challenge.
So, we often talk about the lack of access to computational capacity and compute. That is a great limiter, in addition to access to high quality data as a barrier to engagement in this space. And Brazil, many years ago, made investments in computational capacity. So what I hear for you is that those investments many years ago are now paying off in terms of giving access to that, not just the data, but the computational capacity to allow to analyze that data.
I think it's yet a limit, because Brazil do not produce computer, the high-speed computer. Then these are important material. I think there's a limitation that was put for other countries. Is a huge limitation, but no doubt that the investments, you have a national computer center in Rio de Janeiro. You have here in Bahia, a very important computer center. Then this is was very important, not to give some support, but also to give the training and the cultural, scientific, operational grounds, to start an initiative like CDAC. CDAC was very important, for example, the National Laboratory of Computer Science, that is Rio de Janeiro. People from them help us in this development, Some UK experience for data protection and data was very much important because look, at one point is computer is important, but another thing is privacy and protection. How to create an environment of data governance capable to protect the integrity of the data and the privacy of the people and the involved in the studies.
And I think comes back to the theme that we've been hearing in the last several sessions about trust, right? Unless you have robust governance and privacy frameworks in place, you lose the trust. And I think we have seen examples in other countries where attempts to build these kind of massive population cohorts have not been as successful, largely because of this absence of trust. So I think that's really a point of congratulations to Brazil for having achieved that level of trust that people will be comfortable sharing that much data to give epidemiologic insights to the national level. So let's talk a little bit about you mentioned, partnerships, trust, good quality data, access to computational resources. You also mentioned the importance of building capacity and training people, which I think is really critical. And we know that next year, the baton for G20 will pass to colleagues in South Africa. And your team has now fostered a really rich relationship with, I believe, the University of Cape Town. Is that correct? And so, maybe give us a little bit about how that was established and how we at WHO and other agencies in the room can learn from that experience to build and foster these South-South collaborations.
Yeah, I think this is a very important question, to share our experience and to share with colleagues and then you have been not only with South Africa, but also you have the experience of collaboration with Pakistan. That's why you are so far away, a group in Pakistan. You have a collaboration with Ecuador here on the south near Brazil, but with Cape Town is very interesting. There is two lines of this collaboration. One is that they have a very interesting center linked with the government, the provincial government of Cape Province. And then you identify as a good partner, And in this, you are trying to develop a lot of different things, on interoperability, use of data in different contexts, This is going. They have a link with the University of Cape Town, and then this is linking ourselves with others, University in Brazil, University of Cape Town, and the provincial government. But also with South Africa, later you was contacted. Zami, I think, was one of the person who did this contact. With the cabinet of the president, interested to know about the linkage and data linkage and the use of this data to evaluation of social programs. Then you have been in contact with some technical group of the cabinet, to discuss about that, and to try to transfer our experience to evaluate the Brazilian culture transfer programs and the others, the environmental program that you are evaluating in Brazil, to the cabinet, to them to use this experience to start a large program to evaluate the social programs in South Africa.
So really about not reinventing the wheel, but learning from each other and seeing where we can use that as a starting point to finish. So, Mauricio, you've had a long career and you've seen many positive and negative fluxes in the evolution of technology and innovation. As we talk today about artificial intelligence and the use and application of responsible AI, leave us with one thought. What keeps you awake at night when you think about AI and the potential, but also the opportunities for things to go wrong? What do you lose sleep over?
As a scientist, as a researcher, AI, I have been talking about AI for 20 years. It's not a new thing.
Exactly.
Now the AI is more efficient in terms of can help, for example, to generate text, yeah, to help to write. The young people, my young postdocs, yeah, they are start to use this to do that. You have developed some solution, yeah, it's very important. Some solution, some moment you can maximize the solution via AI. But to the health system, I'm a bit cautious. Yeah, I think there is important advancements. Yeah, I think a lot of things could come. But no one can put all the eggs in the same basket, yeah? I think there is other challenge, yeah, in the health system, yeah, important challenge that are not dependent of AI, yeah, are dependent of resources, human manpower, and the other thing, data, good data, yeah, and the other thing, you have your other function in the health system, evaluation of the health system, monitoring the health system, that you need good data to do that. But a good system of data can include, generate the basis for a good IA development, yeah? And maybe the near future, yeah, you have others, further advancement, and it's certainly, yeah, you collaborate a lot, yeah, to maximize some solution in the health system.
So it echoes what was said at the World Health Assembly a few days ago, that AI is not going to replace our health workforce, but it will. People using AI might replace people who are not using AI. So really augmenting the skills and efficiency of people in the field. So thank you for your insights. Thank you for your work over the years, and exciting, inspiring all of us in understanding the value of good data and good science. So
Okay.
Mauricio, thanks so much.
Thank you very much, Alan. It was very nice to talk.
All right, ladies and gentlemen, how about you take 4 seconds, ignore Bilal freaking out over here because we're over time. Just stand up and let the blood go back to your brain. It's one of my favorite things to do. It's WHO new recommendation that sitting is the new smoking. So you might have smoked, a pack of cigarettes while you're sitting here, but go ahead and shake your body, let your blood flow back through your brain, and then sit back down. So, so what an afternoon, and what a great way to start off our G20. Thank you, first of all, Secretary Ana Estela, for joining today's conversation, and to the Brazil G20 Health Working Group for giving us the opportunity to host this discussion. Thanks to all the co-hosts, and especially Wellcome Trust for supporting this meeting and allowing all of us to get together and share these important conversations. This multi-stakeholder dialogue, which is really what this is, across technical, policy, and civil society levels, is really critical as AI rapidly becomes a central part of our global health journey. It's as Secretary Haddad said, when you were up here on the stage, AI is everywhere. Every department, every ministry, they're talking about AI, and what is our policy? What is our position? How do we use this new emerging technology to everyone's benefit? Just 3 days ago during the World Health Assembly, how many of you were actually in Geneva a few days ago or yesterday coming to, so we'll not talk about the carbon footprint that this is, but you all hopefully chose wisely and came to the high-level strategic roundtable that DG Tedros hosted on AI for health. It was our privilege to help put this together, as there were only 5 roundtables that were hosted by the DG to bring member states together and the general public to talk about the key issues facing global health today. So we talked about AMR, we talked about immunizations, but on that agenda was AI. And so that room was packed. There was 300-400 people in that room talking about the role of AI in health and WHO's role in helping be the custodian of a safe and responsible shift to using this technology. But this space is dynamic. It's filled with sensationalism and very strong opinions, but we have to be guided by science. We have to be guided by science, and we have to be guided by ethics that underscore how we move forward with responsible AI. You've heard this term now multiple times today, And we also have to move forward with humanity at the center. And one thing the DG said that sort of stuck in many of our heads was, using AI has to be akin to using a tool. A tool can be used for good, just like a knife. He used the analogy of a knife. A knife can be used for good. It can also be used for, sticking someone in where they shouldn't be stuck, and it can cause harm. But that doesn't mean we should stop using knives. So I think as we think about this space, that analogy can be drawn out with a lot more nuance, but fundamentally, this is a tool that we need to develop the governance and the responsible ethical parameters around, so we use it with its maximum benefit. And we've come a long way in the past few years, especially as WHO, since our establishment with the International Telecommunications Union in 2018 of the ITU, what's called a focus group on AI for health. Today, we have a tripartite initiative that includes the World Intellectual Property Organization, the ITU, and WHO, known as the Global Initiative on AI for Health. This is helping to curate the global conversation on responsible AI, but also make available the foundational norms and standards around the ethics and governance, and what you heard today by many speakers, the benchmarking and safety testing of AI for health. Just now in our conversation with Professor Mauricio, we clearly heard the importance of how foundations are key to harness AI in an equitable, safe, and effective manner. Investments that we make today in countries around the world, but in many cases, investments that were made yesterday or years ago in standards, in informatics, in capacity, in compute infrastructure, have become key enablers of a robust data ecosystem, and by extension, today, a thriving AI entrepreneurial marketplace. We heard from Secretary Haddad about the optimism and the concern in the Brazilian Ministry of Health, combined with a number of concrete actions that Brazil is taking. We heard from Dr. Mustafa about the potential of AI in extremely low resource settings. We heard about AI being used in the hands of community health workers and rural facilities, combined with the challenges and the risks, such as errors and limited access to computational capacity. Adele Wagaman from USAID gave us some exciting areas where USG is investing in AI to strengthen community healthcare, including an area where WHO issued a formal guidance 4 years ago on using AI for diagnostic radiology. But Adele also spoke to the energy and compute power needs, as well as the risk of hallucinations, inherent bias, and the lack of effective and adequate user engagement. We had Dr. Kiraga inspire us with the leadership of the African Population Research Center, setting up the infrastructure and data sets necessary for African-led AI experimentation and testing that is contextually appropriate. And Dr. Vinbui outlined the opportunities for sophisticated computational modeling of disease dynamics, bringing in multiple layers of data, not just disease incidence, but also climate and population movement and socioeconomic criteria. So it really came across that this is clearly a powerful tool, but it's not the silver bullet, right? It really depends on data quality, it depends on national capacity to be reinforced, and it depends on partnerships and strong collaborations across this room and beyond. I think we also have to be careful not to allow ourselves, and Bilal really started out the day with this message, right? Let's not be caught up by the dazzling lights of the media sensationalism, but really pragmatic realism, right? We have to leave this room kind of immune to that flashing lights of AI can solve all the problems of the future, where responsible AI has to be driven by not just whether AI can be used, but even whether it should be used in a particular context to address a particular bottleneck. So by being here today, you have effectively contributed to moving the global initiative on AI for health one step further. working with the ITU about several years ago, we began this idea of how do we guide this rapidly evolving space. And as we talk more and more to stakeholders and even the nicely articulated priority list that Adele brought up today, this idea of making benchmarking, testing, and tooling available to countries and innovators to be able to assess the quality and appropriateness of the models for that particular problem and for that particular setting is really something critical. And it's something that we at WHO will hope to bring people together to lead. We're also bringing together the expertise needed to continue to develop local capacity, because that's really a theme that I think we cannot underestimate the importance of. WHO has a great convening capacity to bring together many different stakeholders, including the private sector, to be part of this discussion. As the models are being made available to the world, they need to be made available with equity and with responsibility. I think last, we also need to make sure that we are able to maximize the opportunity for AI for health and deliver on the hard work that's needed to get us from the promise and the potential to really delivering on the promise of AI. I think the biggest risk that we face today is of countries being left behind. And I've heard many people say this, not just today, but over the last several months as we've been having more and more conversations about this. Countries simply do not, in many cases, have the capacity to take on digital innovations and AI. What are we going to do to address this? All of us collectively, especially here in the G20 meeting in Brazil. AI has a great potential impact from discovery science with the launch of AlphaFold 3, really leveling the playing field for researchers and bench scientists in low-income countries around the globe. But we also cannot be naive to the risks, right? And I'm saying this over and over because I think it's really critical that you leave today immunized to the shiny object syndrome that we're subject to. We have to require equal investments in the technology, but also in understanding the safeguards. With generative AI bringing renewed interest and investment to this field of digital health, we recognize that this, like the media cycle, is cyclical. And so, Bilal, you said earlier when you launched today's session that we do have a short window. We do have a short window while the attention is on this space to not let it run amok, but to actually guide it in a responsible way to where we want it to go. And this means ensuring governance and safeguards are in place to steward these innovations. Now, let me take a step back and say, the risks, as several have pointed out, Bilal, you made a really good point about the way in which we're testing some of these specifically medically trained models and how a slight modification of the information that's provided or the prompt that's provided can result in actual harm being caused. And so, in the media, we hear about the rare search results. Someone types in, how many rocks should I eat for breakfast to an AI? And it says, well, 5 rocks is about a good amount, and these rare, silly things make us go, oh, AI, you're being silly, go home. We don't take it seriously. But in health, the consequences are real. The consequences can be deadly. And I think that's why it's so critical that we be enthusiastic, but we also make sure we have the necessary safeguards in place. So let me close with a few key takeaways. First, the importance of collaboration and partnership cannot be overstated. And we have to have strong multi-stakeholder partnerships with private sector, public sector, international organizations, academia, in order for this to be successful. Second, equity and inclusion are key pillars. AI technologies have to benefit all populations, especially from our vantage point at WHO, but I know many of you share those key values. It means we design systems with diverse data sets and avoid biases from its initial manufacturing, and that equity has to be in the heart of our AI strategies. So as Melanie stated, ensuring that countries have the capacity to build and engage in AI solutions locally is part of that equity and inclusion issue. Third, we need regulatory and governance frameworks. So robust policies and regulatory oversight are not something that we will deal with next year. We have to deal with those now as the AI snowball is accelerating down that hill. These frameworks shouldn't stifle innovation, but they should promote safe and responsible use of AI. And when we talk about ethical AI, we're talking about things like transparency, accountability, and the inclusion of humans in that process, especially when it comes to health. Fourth, benchmarking AI in cross-cutting areas of priority, such as UHC, TB, computer-assisted diagnostics, cervical cancer screening, AMR. Yesterday, we talked about AI-based ultrasound. These are some low-hanging fruit that potentially could have massive impacts on survival, massive impacts on health outcomes for the most vulnerable of the world. And I think those are some areas we can focus our energy and efforts on. But last, the word is trust. So Stephen Covey has a quote that's often changed and used in different ways, but the quote is, "Change moves at the speed of trust." And so in these early days, given the attention that's being paid to this space, it's very easy for avoidable mistakes or missteps to erode that trust. And this could damage the evidence-based AI strategies, which, as Adele pointed out, with the diagnostic radiology that's already in use in countries around the world, saving lives. Loss of trust can erode those efficacious solutions that WHO already recommends, simply because they're tagged with the moniker AI. So that's something we have to be very, very cautious of. AI has significant potential to impact the way we deliver health and reach our global health goals, but we have to work together to ensure that AI is science-based and augments the capacity of providers to deliver better care and augments the capacity of people to live healthier lives. Thanks so much.